Rheum pathology, polymyalgia rheumatica, fibromyalgia, and polymyositis and dermatomyositis. All right, so first off, let's start off with polymyalgia rheumatica. What you're going to expect here is going to be proximal and bilateral muscle stiffness. Okay. The reason I'm emphasizing this is because you're going to contrast that to polymyositis and dermatomyositis, which has proximal and bilateral muscle weakness. So polymyalgia rheumatica has proximal and bilateral muscle stiffness. This is not that high yield, okay? But remember, it's pain and stiffness in the proximal muscles. And it's going to be highly, highly associated with giant cell temporal arteritis. And that's going to be a vasculitis that we'll discuss in just a little bit. Okay, but it's highly associated with giant cell temporal arteritis. And the patient is going to present with proximal and bilateral muscle stiffness. It's usually going to be a female greater than the age of 50. And your findings are going to be increased ESR, increased CRP with a normal CK. The normal CK is important here. Okay, but that just tells you it's an inflammatory picture. Now, what they want you to know is that treatment for polymyalgia rheumatica is just a rapid response to low-dose glucocorticoids. So if you give them low-dose glucocorticoids and they rapidly respond to it, it's polymyalgia rheumatica. So not too much high yield here. The key takeaway is proximal and bilateral muscle stiffness, okay? It is associated with giant cell temporal arteritis, and it has a rapid response to low-dose glucocorticoids. Next is fibromyalgia. The way that I think about fibromyalgia, it's going to be a female in her 20s to 50s, and it will usually almost always coexist with some type of psychological disorder, like depression or anxiety, okay? Very high yield to know that. Okay, if you see depression and anxiety in their past medical history and the patient has tender points, okay, so tender points, chronic widespread musculoskeletal pain associated with tender points around their body, then you know it could be fibromyalgia, okay? That's like the key takeaway. Now, everything is usually normal. They have normal inflammatory markers, ESR, everything's normal. So they think that because it coexists most of the time with like a psychological disorder, they like to box fibromyalgia in a psychological disorder as well because everything is normal. All their inflammatory markers are normal, okay? So once again, if you see a female 20 to 50 with a past medical history of depression or anxiety, and they have widespread musculoskeletal pain with tender points, fibromyalgia is your answer. Next is polymyositis and dermatomyositis. This is your highest yield thing for this section. Very, very high yield. You'll have a lot of questions on it. So let's first start off with what you'll expect. You'll expect proximal and bilateral muscle weakness. So it won't be muscle stiffness. It'll be bilateral and proximal muscle weakness, okay? Now, you're going to have elevated CK, which is different than the others we discussed. And this most specific antibody is anti-Jo, which is a tRNA synthetase or histidyl tRNA synthetase antibody, okay? So they want you to know anti-Jo1 is a tRNA synthetase antibody. So you have to know that, and it's highly specific for polymyositis and dermatomyositis. You have to know that, okay? That's like the key thing you have to know. All right, so let's start off with polymyositis. Polymyositis is progressive symmetric proximal muscle weakness, as we just discussed, okay? And it's characterized, what they want you to know, by endomesial inflammation. Endomesial inflammation, okay, so that part of the muscle. And it's CD8 positive T cells are associated. Okay, so that's polymyositis. The key thing, endomesial inflammation and CD8 T cells. So this is how I remember. When writing polymyositis, I write the P very, very close to the O in polymyositis. So it looks like the circular portion of the P is sitting right on top of the O. So it looks like an 8. It looks like it makes an 8 when you write polymyositis. And so that 8 tells me that it's CD8 positive. And 8 starts with an E, so you know that it affects the endomesial inflammation, E for endomesial. All right? That's how I remember polymyositis. You probably think I'm the stupidest person alive, but I promise you that it works. Next is dermatomyositis, okay? This is going to be very similar to polymyositis, but the thing is, it also involves like some type of dermatological conditions, hence the name dermatomyositis. So it has the same presentation of polymyositis, but it also involves dermatological pathologies. The first one's going to be gastropapules. Okay, they ask about each one of these. Gastropapules, look at your fingers, okay? There's photos of them. Look up gastropapules. They will show you photos of people's hands, and you have to know that it's gastropapules, and you have to know that they're talking about dermatomyositis, okay? Number 2, they will say that there's a heliotrope violaceous edema of the eyelids. Okay, if they show you that, they're talking about heliotrope edema of the eyelids, which is just like violaceous edema of the eyelids, That is another sign. If they show you a photo of it or if they describe it, they're talking about dermatomyositis. You have to know that. Number 3, you'll see a shawl and face rash. Okay, that's very high yield. Look at what that looks like. Lastly, you're going to be seeing mechanic's hand, which is like thickened and cracked, irregular, dirty appearance of their hands and the digits of their skin. Okay, they usually will have like at the end of their fingers like these like things. Okay, look at every single one of these complications. They ask about every single one of these complications for dermatomyositis. You should know it. Lastly, you have an increased risk of occult malignancy, specifically adenocarcinomas. Increased risk of adenocarcinomas. You have to know that. Very high yield. Okay. Now, the last thing, it's going to be perimesial inflammation, and you'll have atrophy with CD4 plus T cells. Okay, so it's perimesial inflammation. Now, for the CD4 plus T cells, remember, it's very easy. If you just remember the polymyositis with the P over the 0 or over the O, then you know that looks like the 8, and then E for 8 is also E for endomesial inflammation. Then if you just remember one of them, the polymyositis one, you'll remember dermatomyositis is CD4 and perimesial. Okay? So you have to know this. All right, you have to know this. So polymyositis is just proximal muscle weakness with CD8 positivity and endomesial inflammation. Dermatomyositis is also proximal muscle weakness with CD4 positivity and perimesial inflammation, along with dermatological issues. Okay? And you're going to treat all of this with systemic glucocorticoids. So treatment is immunosuppression. You have to give them glucocorticoids. All right? Now, I kind of want to run dermatomyositis one more time so you know it fully. Dermatomyositis is going to be proximal muscle weakness, a heliotrope facial violaceous edema of the eyelids, Gottron's papules, so like a knuckle rash, and you'll have perimesial inflammation and atrophy leading to dysphagia and myocarditis. So the perimesial inflammation and atrophy can cause dysphagia and myocarditis. Okay? And it can increase your risk of adenocarcinoma anywhere. It could be of the ovaries, of the lungs, of the pancreas. Increases your risk of those adenocarcinomas. And it's CD4 T cell mediated. Okay? So that is your dermatomyositis. Lastly, for both of these, you have anti-Jo1, which is tRNA synthetase positive antibodies. All right? So remember this, polymyositis and dermatomyositis are very, very, very high yield. I cannot tell you how high yield they are. They're very important. Okay? Now, lastly is myositis ossificans. This is just when you have trauma to like a portion of a muscle. And since that trauma is so hard, like blunt muscle trauma, it will literally cause it will present as a soft tissue painful mass like in the muscle, and what happens is you literally will have like metaplastic bone surrounding areas of fibroblastic proliferation. So that's what you see on histology. So it literally means that trauma occurred so hard that your muscle turned into bone, and that's myositis ossificans. Not too high yield, but just remember, it's going to present as a painful soft tissue mass, usually after muscle trauma, usually in the region of like quadriceps muscle, and the histology is going to show metaplastic bone surrounding areas of fibroblastic proliferation. All right, that's all.